is autoimmunity and diabetes. I've been very kind. I'm extremely thankful to Dr. Alok Kanungo for giving me this opportunity to talk, and it has been my privilege to talk at the NUCD right from the time the first NUCD started to happen nearly 9 years ago. Why did I choose autoimmunity and diabetes and not type 1 diabetes? Diabetes, as you know, can occur in any age group. And autoimmunity in diabetes can also occur in any age group. If people think that it occurs only in the younger individual, they are wrong. Autoimmunity predominantly occurs in younger individual, but more and more research tells us that autoimmunity can occur in older individuals also in larger frequencies. There are quite a lot of advances that have taken place in the last 1 year that tries to tell us how the disease starts and how the disease progresses. Some of the top class studies that are going on in the field of autoimmunity and diabetes have been coming out with some extraordinary findings. One of them is TrialNet, that is exceedingly good. Another is Type 1 Diabetes Genetics Consortium, which is financing a study that involves following children from birth until they develop diabetes. You might hear from Alok Kanungo the diabetes that occurs in older individuals with autoimmunity called as LADA. So there are different stages of type 1 diabetes, since LADA is going to be covered by Alok. And these are the stages that are depicted in this particular cartoon. So everybody should have a genetic risk for developing type 1 diabetes. So genetic risk is the important starting point. And there are a variety of risk factors that you will see, whether you are in a family with somebody having type 1 diabetes or you have no relatives with type 1 diabetes. So there is an immune activation, and this immune activation usually triggered by environmental agents or viruses or some other stressful events in the life of the child. So this immune activation starts by destroying the beta cells slowly. And over a period of time, lots of beta cells die. When many beta cells die, what happens is that you develop autoimmunity. With the result, autoantibodies, which are the markers of the disease, start appearing in the serum, leading to identification of these autoimmune markers and diagnosis of autoimmune diabetes. So there are several stages in which these autoimmune diabetes can be picked up. In stage, you have normal glucose tolerance, but you have 2 or more autoantibody positivity. In the next stage, if there is a continuous destruction of the beta cells, you have 2 or more autoantibody positivity, but in addition, you have abnormal glucose tolerance test. This could be identified by intravenous glucose tolerance test or with more loss of beta cells, oral glucose tolerance test. So when there is some kind of an event that happens that could even be an infectious disease or a stressful event, the clinical diagnosis of diabetes can be made when the patients appear to the clinic or the hospital with symptoms. This is when it all happens in terms of what you can do to these patients. When you have these patients coming to you with clinical symptoms, you can assume that 90% of the beta cells are gone. What one can do in terms of arresting the beta cell damage is to try and prevent further damage and retain this 10% of beta cells so that you do not develop ketoacidosis or ketonuria. This is a very important complication that can kill the patient. So what are these stages that a clinician should know so that he can pick up these stages much earlier before the clinical onset? Because the TrialNet is one important aspect that will help identify, including the Type 1 Diabetes Genetics Consortium, that tells us how to pick them up. If you pick them up early, there are a variety of things that you can do to help them delay the onset. So when you look at the stages in Type 1 diabetes, there are multiple antibodies in stage 1, normal blood glucose, pre-symptomatic, no symptoms. Then in the stage 2, as you saw in the previous cartoon, multiple islet antibodies, raised blood glucose, pre-symptomatic. This signifies there is considerable loss of beta cells. Then in stage 3, you have islet autoimmunity, you have raised blood glucose, and the patient becomes symptomatic. The stage 4 is those patients who have long-standing diabetes. And the question will come whether there is anything you can do to reverse the long-standing type 1 diabetes, which is possible with some of the advances that are being made, but we still haven't got any approval for some of these things that can reverse the type 1 diabetes. Either it could be due to vaccine strategy or it could be beta cell replacement therapy. So in stage 1, individual test positive for 1 or 2 or more autoantibodies. The immune system has started attacking the insulin-producing beta cells. When we say immune system, the predominant cell in the immune system that attacks the beta cell is T cells. And the blood glucose levels remain normal and no symptoms are present. Whereas in stage 2, the autoantibodies develop due to an autoimmune reaction after the T cells attacking the beta cells, releasing the contents of the beta cells. The GAD is actually intracellular, it's not extracellular. So the contents of the beta cells will have to be released for your immune system to react to the GAD or to the insulin, so that there are antibodies that are developing to these things. But these antibodies are only markers for the disease, which is very important for us to measure them in order to identify who are likely to develop type 1 diabetes. Stage 3 is important. Type 1 diabetes symptoms are present, and it is due to the significant loss of beta cells. Almost 90% of the beta cells are lost at this stage. The common symptoms include increased thirst, urination, unexplained weight loss, blurred vision, and fatigue. These are a little bit non-specific. What will happen is that in a poor or middle class or lower middle class families, they may not be able to identify these symptoms as specific for diabetes, seek medical advice. Sometimes they will ignore. And when that happens, these patients lose all the beta cells and then develop ketonuria or ketoacidosis and present to the hospitals with these symptoms that are a little bit more acute than you would normally when these symptoms show up. So there are 3 stages, stage 1, stage 2, and stage 3, which are the stages that progresses the type 1 diabetes from genetic risk to the exposure to the virus and to the development of clinical symptoms. And these are the clinical symptoms that I enumerated in my previous slide as well. And these clinical symptoms is the time when the doctor sees these patients in the hospital. But it would be very important for us to know whether it's possible to identify these patients a little early. The most important aspect here is the genetic risk. Without genetic risk, development of type 1 diabetes is very, very, very low. It can happen, but it's very low. So the genetic risk is determined predominantly by the HLA molecules, which are called as HLA class 2 molecules. And in the class 2 variety, DR3-DQ2 and DR4-DQ8 are the predominant high-risk HLA that confer susceptibility to diabetes. Many patients have both DR3-DQ2 and DR4-DQ8 that increases the risk substantially. But in Indian context, it's more important to know that DR3-DQ2 is much more important for risk for development of autoimmune diabetes compared to DR4-DQ8. So type 1 diabetes starts with the genetic risk, genes that put you at high risk for the disease. The risk for people in general population with nobody in the family having type 1 diabetes is about 1 in 300. But for those who have a family member with type 1 diabetes, the risk substantially increases at least 15 times, where the risk is there in 1 in 20 individuals. So it's important to know that for the physicians, the relatives of people with type 1 diabetes are 15 times more likely to develop type 1 diabetes, the disease, than the general population. So if there is a family that comes and tells you that they have a child with type 1 diabetes, it's important for you to ask them whether there are any other children, especially children younger to the patient who have developed type 1 diabetes, so that you can start screening them and trying to see whether there are any markers that develop. And some of the tools that you will see might be very interesting to implement at this particular stage. There have been a lot of debate whether the beta cells actually express the HLA class 2 molecule. Many of the people felt that the beta cells do not express. But now, in December 2022 in Diabetologia, a paper from Matthias von Heret's group have clearly shown that there is an upregulation of HLA class II molecule in the pancreatic beta cells from organ donors with type 1 diabetes. This is a very important finding where a direct infection of the beta cells can cause upregulation of the HLA class II molecule that are high risk for susceptibility. And this could actually trigger the T cell immune response, leading to the destruction of the beta cells over a period of time. If the risk is higher, if it is DR3-DQ2 and DR4-DQ8, the chances of losing all the beta cells is much faster compared to one of them, either DR3-DQ2 or DR4-DQ8. It's also important to know, in the recent paper, again, published in the last 1 year, it is clear that a particular DR called DR15-DQ6 remains dominantly protective against type 1 diabetes. What does this paper clearly show is those people who carry DR15-DQ6, previously we knew that it can protect only children up to the age of 10. But now this evidence shows that it protects individuals from developing type 1 diabetes until the age of 50 or 5 decades. So this is a considerably important finding, and this finding is possible only because the sample size is really large and you are screening patients right from birth. It is the T cells that cause the disease, and you can see in the recent paper published in Nature, a subset of T cells branded as the seeds for type 1 diabetes. And this paper was the first author of the paper for GRT. And it's a very, very interesting paper, how the T cells drive autoimmunity, leading to the development of type 1 diabetes. And in this cartoon, you can see in a normal situation with a chronic viral infection, it is the viral antigen that gets expressed on the HLA. And this is what leads to the cells exhibiting the HLA to die by the effect of T cells. Whereas in a type 1 diabetic scenario, if the pancreatic antigens bind to the molecule, the HLA molecule, then it leads to the destruction of the pancreatic beta cell. And this becomes important in the light of the finding that the HLA molecule gets expressed in the beta cells directly, which is a very important step for us to know that the destruction starts with the T cells. So autoantibodies are the markers of the disease. They are the result of the disease. They are not cause of the disease. And these are the important autoantibody markers that needs to be measured in order to identify the risk. Some will have only GAD antibodies. Some will have islet antigen 2. Islet cell antibody is a measurement of antibody using immunostaining, where anybody who is positive for ICA could be positive for GAD. You also have another assay, insulin autoantibody, which has got a new assay, microinsulin autoantibody assay, which is what was formerly called as IAA, and a zinc transporter. So these are the antibodies that are measured, and presence of 2 or more antibodies signifies clearly the existing autoimmunity and the loss of beta cells that is happening in these individuals. So where are we with type 1 diabetes in terms of prediction and in terms of prevention? There has been much progress in this field. One of them is the pancreas transplantation or biological replacement of islet cell functions achieved by pancreas transplantation with islet transplantation. So the islet transplantation is a very interesting area. Either you can harvest islets from cadaver donors from their pancreases, or we can have stem cells developing into insulin-producing beta cells. These stem cells could come from human embryonic stem cells, or it could come from cells that have been stimulated, the pluripotent stem cells that can offer through a technique called inducible form of pluripotent stem cells. So another potential strategy is to introduce robust beta cell replication so that regeneration of islets can be achieved. Maybe there is a drug candidate that will allow this to happen. And there are some interesting publications to tell us how this can happen, the regeneration of islets. The interesting part is the immune interventions are being studied with the hope of arresting the type 1 diabetes. And most of the immune intervention strategies have approached only one immune intervention. Either it could be GAD vaccine, or it could be a vaccine for one of the viruses. But now it is possible to have a combination of these in order to increase the protection that could be given to the beta cells from these immune cells attacking them. The interesting part, simultaneously, what is happening is the mechanical replacement of islet function is happening with the use of glucose sensor controlled insulin infusion system. So what your pancreas does, you can have a machine do it and have the machine outside the body connected to the body with some kind of microtubing that will allow continuous estimation of blood glucose and infusion of insulin. So all these avenues are pursued. Headlines often overstate the case. So when somebody comes up with one particular approach being successful, there's a whole lot of newspaper articles that claim, oh, we have found a cure, we have found a cure. But it is not actually the case because we are still making a lot of progress. And some of the cures does not apply to everybody. So this was the paper published by Jay Schuyler in Diabetes Care, where he is showing variety of approaches, and he is emphasizing that a combination therapy using these agents with complementary effects will have a great value in terms of delaying the destruction of the beta cells or even prevention of beta cell destruction taking place. It's all the question of the timing. When do you time this? And this will ensure how much of beta cells you can save. So with these approaches that are being done, what had happened in the last 1 year is there has been an exciting development with a monoclonal antibody called teplizumab. Teplizumab has been tested, which is an anti-CD3 antibody in the first degree relatives of patients with type 1 diabetes. So these are at-risk patients. And this paper was published in New England Journal of Medicine. And teplizumab delayed the progression of clinical type 1 diabetes in high-risk participants in TrialNet cohort. TrialNet is a cohort where they have a lot of patients with type 1 diabetes markers who are relatives of patients with type 1 diabetes who are being followed up regularly. And these are the candidates who are being taken for these clinical trials. So teplizumab is delaying the onset at least by 2 years in this follow-up study. And what had happened was that US FDA has already approved teplizumab for patients with antibody markers who haven't developed type 1 diabetes, who can receive teplizumab. And American Diabetes Association has given a very nice note on this, that teplizumab So there are some more clinical trials that are going on, which if could be complemented with teplizumab, it could probably delay the onset of type 1 diabetes even further. Some of the interesting things that we may have to know outside the area of medicine, outside the area of drugs, is can diet cure or can diet be the cause of type 1 diabetes? So there has been a study where it was published in one of the prestigious journals called Cell. A low-calorie, low-protein, low-carbohydrate by high-fat fasting mimicking diet was given to mouse. And these fasting has resulted in regeneration of pancreatic beta cells. So these regeneration in the diabetic mouse has resulted in the reversal of diabetes. So fasting has been one of the important things that we had been practicing over the centuries in India. And it's important that we continue to do this fasting. And it's a clear evidence now that fasting helps in beta cell regeneration and reversals of diabetes in individuals who may have diabetes. So fasting in a diabetic individual needs to be done, of course, with dietary supervision by the nutritionist as well as by the doctor. It cannot be taken by the patients by themselves as a way to reverse. But this is something that is very interesting. And it's important that we follow this carefully. And those people who are at risk for diabetes, they might find it beneficial to prolong their disease-free state for a considerable amount of time. You know, celiac disease and diabetes are relatives. Patients with celiac disease, 1/3 of them develop type 1 diabetes, and nearly 10% of the type 1 diabetic patients develop celiac disease. Both have a similar etiology. Both have HLA-DR3, DQ2 as the high-risk HLA. When you look at these features of celiac disease and type 1 diabetes, sharing with this. Gluten is a diet-induced celiac disease. So if you prevent intake of gluten, you can reverse celiac disease. This is known fact. But what has now come out with animal studies, which is now being followed up in the humans also, is a gluten-free diet reduces autoimmune diabetes in mice across multiple generations. And right now, in the type 1 diabetes cohort in Sweden, they have tested gluten-free diet in high-risk individuals, meaning that those individuals who have high-risk HLA plus autoantibody markers. And the early results show that gluten-free diet is extremely beneficial in individuals who have high-risk HLA as well as high-risk autoantibody markers in delaying that diabetes. We do not know how much delay it had happened. We can expect a publication in this very soon in the next couple of months. So the conclusion is gluten-free diet reduces autoimmune inflammation in salivary glands and pancreas in odd mice in a microbiota-dependent and independent manner, respectively, and has preventive effect in type 1 diabetes. So this is a very important change that the clinicians might find it very interesting. Hopefully, we will have this results available in the human beings that should throw a light on how a gluten-free diet, which is anyway being practiced by patients who have celiac disease, could also be used in either patients with type 1 diabetes or patients or individuals who have high-risk diabetes, high-risk markers for diabetes. So these are some of the very interesting developments. Teplizumab is one, gluten-free diet is another, and fasting, of course, is very important. And all these things help us understand that the diabetes is something that we can really take control of. So tissue transglutaminase is the antigen, and in the celiac disease, and antibodies to tissue transglutaminase clearly identify celiac disease. So we need to document celiac disease in a type 1 diabetic patients by doing this test. Or if there is a celiac disease patients who are tissue transglutaminase antibody positive, then you need to have GAR antibody and IA2 antibody tested to establish diabetes. If somebody has both, then of course, gluten-free diet is going to be extremely beneficial in decreasing the manifestation of both these diseases. So this is a very important finding that I would like you to have it as a take-home message. So with this, I thank you very much for your attention. And if there are any questions, I'll be happy to answer these during the panel discussion. Thank you.